So one of Health Education England's functions is to ensure that the current health workforce is regularly updated, and this obligation to maintain your professional accreditation should now include understanding of the importance and the value of genomics, access to understanding of the power of those tools and the ability to use them. And for me, the main point is that we need, as well as those values in our medical students, we do need to encourage the value of lifelong learning and recognising that there's such a rapid evolution of health knowledge and technology that you do need to enable people to maintain their professional competence throughout their working lives. And that also needs regulation, because a lot of people are lazy and won't do that unless there's a reason to do it. So you can either create incentives for learning, or you can have regulation to make sure that people do comply with necessary requirements.
Well, for the last question, do we have the last question here? If no, I would...
May I ask Dr. Aika, because he's going to join another meeting. I think you have something to conclude.
Thank you very much. The very productive discussion between the panel and also the participants here. My kind of conclusion is that I would like to propose that we should revisit again the kind of multi-sectoral coordinations. Sectoral coordinations which brings all the relevant stakeholders, particularly ministries, and also professional associations, private sector, to discuss how best we can increase the investment in the health workforce. It was multi-sectoral coordinations. It's once well highlighted, maybe sometime 10 years ago or so, but recently I never heard about it very much. We should have maybe more formal coordination mechanism. This is a bit ambitious idea, but more formal coordination mechanism under, not within a part of the Ministry of Health, but maybe under the President's or Prime Minister's office or so. That will help, and also not only Ministry of Health, Education, Labor, and so forth, but we should get definitely Ministry Economic Development Planning involved. By doing so, we will be able to more critically and more visually show how important it is to invest more money in the health workforce, maybe at the political agenda, as one of the political agenda. I remember the 2013 or 14, there is a global forum on human rights for health in Brazil, and there is a political declarations. I don't know how well it's being abided by. So we should revisit again the importance of the multi-sectoral coordinations to make investments in the health workers national agenda. That is kind of my idea. So I don't know whether I'm right in the right at this stage, but I have to leave this session to the next door after the maybe you have break, right?
And you come back here.
Maybe I'll try to be back, but that's my kind of tentative conclusion for this session. Thank you very much.
Thank you, Ms. Professor Aga, and now it's the time for the last presentation.
Right now, we invite Dr. Suwit Wibulpolprasert, who are global leaders on universal health coverage to
global troublemaker. I didn't know that I have to be here. But I expect Jordan Thompson to be in another room on drug system, but he disappeared. But anyway, he's here.
Sir, you ordered me to come here. And I always complied with this biggest troublemaker in the world.
This man is my guru in making trouble. Anyway, I was asked to talk about the global perspective on investing in human resource for health. I want to share with you 4 issues. First, many countries, many people ask me how Thailand achieved universal health coverage at only $2,000 per capita back in 2001. They want just one, the most important factor. Don't tell a bunch of factors, but just one. And my answer to them was, because we have committed, qualified health professionals. Because universal health coverage is not about money. It's about access. It's about effective coverage of essential health services. And it can be only through committed, qualified health workers. Money cannot buy. Money cannot buy this. No matter how much donor money poured in, you will never achieve universal health coverage without committed, qualified health workers. And not doctors. If you depend on physicians or doctors to achieve universal health coverage, you will achieve universal health coverage in your next life. I can guarantee you. I'm a medical doctor myself, I know. More than 50% of essential primary care in Thailand, even now, are delivered by nurses, community health workers, public health workers, not medical doctors. Because most medical doctors like me, we don't want to stay long in the rural area, remote area. We were forced to work there for 3 years, right, Dr. Pudit? Right? When you graduate, you have to work for 3 years, right? How many years you work there?
3 years.
Most clever. Stupid like me work for 12 years. You know, if you ask the doctor in Thailand how many years you work in the rural area, you can assess their intellectual capital capacity. Those who stay short, the best. Like Dr. Vanisha, how many years?
3 years, but right now I work in community again.
Because she get more senior, her intellectual capital come down. So committed, qualified health workers, not medical doctors, that ensure universal health coverage. And it is the job of medical school, nursing school, and the government to ensure that. You cannot expect a rich man or a lady, a girl from a rich family, study 6 years in a cozy, elite medical school, and want to go work in the border, the jungle hospital without any good facilities. You cannot. You have to have a policy to recruit them from the ground, educate them at the ground, and they will go to work at the ground. That's what we did in Thailand. Our ancestors are very clever. Not me. I'm later. I'm a latecomer. It's long before me. That's the policy. Rural recruitment, local training, hometown placement has been the main policy of producing health workforces, investing in health workforces in this country. Right now, about 40% of medical students are recruited under the so-called collaborative program to increase production for rural doctors. They are from the province. They don't have to compete at the national level. We expect to recruit the best heart, not the best brain. Best brain, good brain can be trained. good heart is difficult to build. Okay? Now, second point. This is a proverb which I think many of you know. If you want to invest for 1 year, you sow weeds, get rice, right? Grains. If you want to invest for 10 years, you plant trees, you get fruits. If you want to invest for a lifetime, development. So building capacity is the top priority for health system, for UHC. Unless you invest long term to build human capacity, you cannot achieve universal health coverage, for sure. Or you can achieve, but at a very, very high price. Thailand spends about 5% of our GDP on health, yet we have universal health coverage. And our universal health coverage has quite deep benefit package. Renal replacement therapy are free. Hemodialysis, peritoneal dialysis, kidney transplant, bone marrow transplant, coronary bypass, all free. When I say free, it's really free. No premium, you don't have to pay contribution in order to get the right. When you go to the clinics, the SI clinic, you don't have to pay. No co-payment, no deductible, no co-insurance. Unlike in our Japanese system, they have to pay before they get sick. When they get sick, you have to pay 30%, right?
Yeah.
See, rich countries like that, but we achieve this because of committed, qualified health workers. So invest in human, but not only human. Invest in institute that hold those people. If you train a rural doctor and you send them to the jungle without nothing, without anything, without any institute, without any hospital, they cannot do anything. But you have to train them as fighter, as winner. Back in 1982, the National Medical Education Conference in Thailand, all medical schools resolved to produce medical doctors to man rural hospital, to stay in rural hospital, with 4 main capability. First, to be a good clinician. Those who are not good brain stay in the medical school because they need supervision by professor. Those who are best brain like me go to the most remote area. Because we are good, we can do everything alone. And indeed, I have to be an anesthesiologist, a surgeon, a pediatrician, a manager, a janitor, a plumber, everything. When the toilet is clogged, it's me who have to solve it. Only 1 doctor and 10 staff. So being a good clinician. Second, being a good manager. Because the first day you graduate from medical school, you become the director of hospital. Being a good teacher, because you have to teach community health workers, village health volunteers, and being a primary health care supporter. Did they succeed? Partially, of course. They cannot be totally. But my second point is not only invest in the people, but invest in institute, invest in facilities, okay? And help them to network among themselves so that there'll be self-help. We have, in Thailand, we have a rural doctor society, we have rural pharmacy society, rural dentist group. You know what they did? They usually have meetings. And everyone come with problem because they were thrown into the difficult situation. They face so many problems. They come and they start to tell story. Oh, I faced these difficulties. Another one say, oh, I faced these difficulties, and they share their experience. After a few days, everyone go back home very happy because they release their tension. Right. Most important of all is that they listen to stories from other people who face more difficult situation than them. And they feel that, oh, my situation is not that bad. Huh? That guy is worse than me. And they get advice. My third point, if you want to invest wisely. Make sure that you get the best return. First, focus more on primary care providers, not secondary or tertiary care providers. I'm not against specialists. Okay? I'm a specialist. I have 2 Thai board. Thai board is like American board. I have 2 Thai board. I'm a specialist, equivalent to PhD. So I have 2 PhDs. And in Thailand, we are very practical. If you work for 5 years in a rural hospital, you can apply for board exam with the Medical Council of Thailand. And if you pass, you get the board, which is like American board, through your own experience and practice. And the Civil Service Commission recognizes it like a PhD. So I have 2 PhD without having go to school. Many rural doctors did the same. If you ask the doctor in my generation, most of them will have 1 or 2 board certified, okay? And you get additional money from the government if you get a board. I think now about $300 to $500 a month. It's not small. Huh? So invest on primary care, community health workers, practical nurse, public health workers, as much as investing in doctors. Second, if you invest, focus on equity. When we propose the project to increase production of doctors, because we lose a lot to the private sector, we intentionally propose the CPER, increased production from rural doctors. We intentionally put a proposal to recruit them from the province, train them in provincial hospital. Right now we have 38 to 40 medical education center in provincial hospital in the Ministry of Health around the country. And this medical education center improve the quality of service of those provincial hospitals, at the same time produce rural doctors. Okay? So equity in education, because you recruit them from the ground. Actually, we even have the 3rd level, we recruit them from the district. Previously, we have a district we call ODOT, 1 district, 1 doctor. You are recruit from the rural district. If you are the first student in the high school, you are almost automatically a medical student. But because those with good best brain, they always go to the provincial urban city to study high school or go to Bangkok. So those who left at the district are not very high grade. And when they go to medical school, they face difficulties. So we pay medical school to give them special tuition, so to upgrade them. And we even give them monthly allowance, about $300 monthly allowance. But when they graduate, they have to work for us for 12 years. 12 years. We don't touch the old group, because if you touch the old group, you face difficulties. Okay? Now, focus on heart more than brain, as I have mentioned. Focus on social and managerial capacity, not only clinical capacity. Last point, when you invest on human resources, particularly in developing countries, you must be self-reliant. Donor money will not help you in the long run. The best is to not to accept any donor money. You have to invest by yourself. How much you have to invest to produce community health workers? It's token of money. As compared to build a big tertiary care hospital, you can produce tens of thousands of community health workers and hire them at very low price, very low salary. Because they are there, they are local people there. And they can provide 80-90% of primary care services, many times better than medical doctor. One of our professor in OBGYN did a study long time ago, 30 years ago, compare a midwife with only 1.5 year education after high school, and a medical doctor 6 years education after high school. Best brain, more training, not very good brain, short training. This is an OBGYN professor. He compared the insertion of intrauterine contraceptive device, IUD, between these two. This one in the rural health center, this one in the hospital. Can you guess the result? This one did much better, more safer, less complication, as effective. Why do you have to pay for a high price and less effective, more complication? Health personnel. Let me tell you, I'm 22 years in the capacity of member of medical council by election. So I speak as a medical doctor who know all this and work with them for a long time. So invest wisely. Don't depend on JICA money, USAID money, or state money. No, depend on your own money, your own capacity. You have it in your country. We started since we are $400 per capita to produce all these health workers. Why do you have to depend on the Swedish money and be bullied by John Thompson?
We never gave you any money. We are wiser than that.
Thank you so much. Thank you for the organizer of this.
Thank you, Dr. Suwit, for sharing his inspiration point of view to improve the healthcare system in Thailand. So it has been such a great morning already. We still have many interesting discussions waiting for you after the coffee break. Please be back on time. We will start the session again at 11:25. Thank you very much. We will 15-minute break.